Good morning, everyone. It's with great pleasure that we welcome you to today's seminar. We understand you're following this event on as registered participant, but many of you are also connected via live streaming. Thank you all for this overwhelming participation. It means a lot to us. I would like to let you know that the Q&A facility is available only for the registered participants. When you write a question, please select the option All Panelists so that everyone can see it. Considering the large number of participants, we'll be only answering a few relevant questions and may not be able to answer all, but we'll try our best. So thank you. We'll begin in a few minutes. Once again, a warm welcome and hope you have a great day with us. Thanks.
Good morning to everybody, and my name is Andrea Biondi, and I would like to extend my very warm welcome to all the participants and the speaker for this today academic seminar dedicated to SARS CoV2, the vaccine development. And before starting the program this morning, I'd like to share a few words about the Virgilio program. So let me just in 1 second share my slides to all of you. The Virgilio program is a very exciting program which has been funded by the Fondazione Cariplo. And in that sense, I'm very pleased to thank even this morning and even more Dr. Giambattista Sciombo and Dr. Pozzoli, who are very keen to support the program since the beginning. And I have to say that they were very enthusiastic about this program. The Virgilio program is a pre-graduate research track for training physician scientists. And it's a joint program between the University of Milano-Bicocca, the University of Milano, and the Humanitas University of Milano. And as I mentioned before, it's been financed at the beginning by a specific grant by Fondazione Cariplo. The aim of the program is to develop and train medical students who are interested and deepening during the course of medical school of understanding research methods and ethics of research, and try to link as much as possible the idea between basic science and clinical science research. And of course, the objectives are highlighted in this slide, just to introduce medical students to the physician scientist career path, to train students in scientific attitude, to raise questions, and more important, to try to connect basic science in biomedicine. And finally, to provide mentored research experience to explore translational medicine as a career choice. How is structured the program? The program is a 3-year program starting from 4th years of the medical course of medicine. Is a merit-based selection. So only the students are qualified and strongly motivated to do that are basically selected through the process in the context of the different university. And these are basically the program structure by providing supplementary training courses, which are basically spread over the 4th, the 5th, and 6th years. And during the same time, we are offering a lab rotation, which basically offer to the students the opportunity to touch with their hands the experience in the lab. And this is very important because it's probably the only way to at least to approach or to some extent understand what can be the chance, even think about the future of a scientist, a medical scientist career. The overall academic credits is 60 additional credits to the ones which are basically provided by the medical course. And as I mentioned before, There is the offer of didactics, which are basically courses designed to acquire knowledge and skill related to scientific methodology, biostatistic, scientific and grant writing, communication, ethical responsibility, alongside subject-specific courses. What I think is very important that at the end of the 6th year, when the medical students are getting the opportunity to do the final thesis, it's very important that the students can select one of the different university where to spend and to prepare the thesis. And this is another important issue to offer and to strengthen the link between the 3 medical schools, which are basically funded the courses. Another important issue that each student can identify one mentor. And one mentor is one of the physician scientists of the medical school board of each university, which basically can guide or at least can help the students to offer research experience, even in terms of what can be at this time of my path a good choice and a good opportunity to think about, even in terms of spending time abroad in different labs. The second important level, that the time a student spends in each lab is followed and supervised by tutors, which is basically young scientists who guide the day-to-day research experience of the students using the lab rotation and provide to some extent academic support for the thesis internship. And finally, of course, the lab PI will support the placement of the students. These are basically the benefit. Of course, we are thinking on how to provide a stronger benefit of this a very intensive opportunity we are providing. And we are thinking about jointly that this might be something to provide some credit for the students who are interested to get into a PhD program, but it is still in program and in place. And so far, these are basically the benefits provided to the students. And finally, if you are more interested to get more information about the program, please digit the website of the program in our Bicocca web page. But as you can see, there are many places through which you can get more information and link and even interview with students who have basically already completed the program. So this is just to say a few words about the Virgilio program. But today we are not here just to talk about the Virgilio program, but we are here to have an exciting morning to talk about the SARS CoV2 vaccine development. I don't think that we do need to spend much words to explain what are the experience. You will listen in the Anthony Fauci interview and seminar that the pandemic that we are experiencing today is one of the worst pandemic that we are definitely experiencing in the last century. And this is something that we are fully aware for this situation and the lockdown and the impact in our life and in our economic, and more important, for the health issue we are facing daily in our hospital today, for the number of deaths and people who are dying daily in all parts of the world. And this is, I don't think that there is no other words to say. But on the other side, and you will touch upon this morning by the outstanding 2 speakers that will share their experience this morning with us, that we have experienced an extraordinary time on how science was so important, and in the field of vaccine, how speed was the fight to reach the time which we hope will be very soon to a vaccine in order to fight properly this type of very worst pandemic. And this is my short introduction. And now we are moving to the program. And in order to move to the program, I am very pleased to announce that, as you have seen, that we are going to have the opportunity, and I would say the privilege, to have Dr. Anthony Fauci pre-recorded session. And I would like to thank Professor Domenico Maviglio, who provide to us the opportunity to get this link. And the reason for that is very simple. Domenico, who is an associate professor of translational medicine at the University of Milano, and is the principal investigator and head of the unit of clinical and experimental immunology at the lab of Humanitas, has had the opportunity to spend many years to work with Anthony Fauci. And accordingly, it was so kind to provide the opportunity of this morning first session and first contribution. And I would like to introduce again Domenico with another aspect, which I think is very important for the Virgilio program. In his first talk, Domenico will present to us Anthony Fauci career, not just by describing the major achievement, but to highlight how it was important for him as a physician to move the step forward to become an outstanding medical scientist and well known to everybody. And so I'm very pleased to introduce again Domenico Maviglio, who is graduated as medical school and completed his residency program in internal medicine at the University of Genova. Then he obtained his PhD in clinical and experimental immunology within a joint program between the University of Genova and the National Institute of Health, specifically the Institute of Allergy and Infectious Disease, under the mentorship of Anthony Fauci. So I hope they will enjoy this morning. And please, Domenico, I will leave the ground to you.
Thank you very much, Andrea, for the nice introductions, and good morning to everyone. So without spending any more words, I will share my screen in order to share my presentations of lifetime's achievement of Dr. Fauci. I hope you can see my screen now. Andrea, can you see my screen? Okay.
I can see.
Okay, good morning to everyone.
Yes.
My name is Domenico Maviglio. Thanks, Andrea, for the nice introduction again. And I'm an immunologist from University of Milano, working at Humanitas Research Hospital. And my duty to do today is basically to introduce to all of you to the career and the achievements of Dr. Fauci. So as soon as Anthony Fauci accepted our invitations to join this academic symposium, we soon agreed with Professor Biondi, with the other mentor of the Virgilio program, that it would have been extremely helpful to have an introduction explaining to you why Dr. Fauci is indeed Dr. Fauci and why he represents a seminar, a reference, and a pioneer like for generations of science and doctors. Especially in the context of the target of these symposiums, the Virgilio program, the medical students, that indeed the Virgilio programs, as Andrea said, has like the ambitious aim to educate and train the next generations of physician scientists. Why I'm doing this? I'm doing this, as Andrea said, because as soon as I completed my degree in medicine, and I was in the middle of my residency program, I had the opportunity to join the Dr. Fauci group. And he mentored me for 9 years, first as a young postdoctoral fellow and then as a research fellow. So I hope I will be able today to transfer some of this way to approach science. But let's start. So if you Google search the name Anthony Stephen Fauci, I'm sure you will find everything. It's almost everything or everyone. But I don't want to list the prize and achievement of Dr. Fauci today, but I want to focus on two issues. The first is being him a medical doctor, and so a medical doctor that paved the ground and set the stage for translational medicine and translational immunology by being one of the pioneeristic physician scientists. And the second, his involvement in public health programs. Let's start from the very beginning. So he was born on the Christmas Eve of 1940 as a third generation of Italian Americans, which means that his parents were born in the US, but his grandparents were basically Italian immigrants. From father's side, they were coming from a little town close to Agrigento, Sciacca, while from the mother's side, they were coming from little towns close to Naples and Genova. And he was raised within Brooklyn and within the Italo-American community, but he was raised as a next generation of Americans, because being Italian back then in the 40s and the 50s was not that cool as it is now. Yet in the mid-50s, he attended the Regis High School in Manhattan, where he developed since then his high interest for science and anthropology. Indeed, he later declared in a public interview that at that age in high school, he liked the experimental nature of science that could solve with scientific methodology problem of humanities. Hence, given his natural predispositions and affinities for public health science, he decided to go for a medical career. Hence, after completing his degree at Holy Cross College in Worcester, Massachusetts, he was admitted to Cornell Medical School in New York. It was very important to point now that back then, he had no intentions at all to become a physician scientist and going back and forth to the lab. Actually, his perspective was just to become a regular doctor and attending physicians. But soon the time of choices came for Dr. Fauci after his graduation in 1966. Indeed, there were very historical and challenging time in the US. Indeed, the US was involved in one of the most brutal and cruel and politically committed wars, which was the Vietnam War. At that time, all young American medical doctors were drafted by the US government for military service. But different from the regular drafting among US citizens, they were given a choice. They could choose whether to serve the public health services or the Army, the Navy, or the Air Force. Dr. Fauci chose and applied to go to NIH. NIH is a big American institution, a truly public institution, which is the American counterpart of our Istituto Superiore di Sanità, who belong to the Department of Health and Human Services, which is the American counterpart of the Ministry of Health. In particular, Dr. Fauci soon joined the National Institute of Allergy and Infectious Disease, and from then on, it became his home, and that he will never leave through all his medical career. And then Dr. Fauci has several lives. Let's start to basically show you the lives of Dr. Fauci, how he got up to today. So the first Fauci was a basic immunologist. So Dr. Fauci in 1968, when he started to work at NIH, started to explore the whole sides of infectious disease in a time when investigating on infectious diseases literally meant studying the futures of microbes. So having a microbiology approach. Indeed, human immunology was back then in its infancy with real limited knowledge. We have to think that B T cells were just discovered, the T cells or natural killer cells were yet to be discovered, and the TCR receptor was cloned only more than 10 years later. So host pathogen interactions and related innate adaptive immune responses had never been investigated back then and neither hypothesized because they were in large part unknown. At that time, also Dr. Fauci completed his medical education and was certified by the American Boards of Infectious Disease and Clinical Immunology. So in that 5 years, he carried studies of fundamental basic immunology with both animals and human models. Then the second Fauci came. So as soon as he completed his medical educations, clinical educations, he started to study the regulations of immune systems in model of human disease. So basically what he was doing, he was start transferring his clinical question, his unmet clinical needs from the bed of patients to the bench of the lab, and taking back the answer to these questions to the bed of the patients. In other words, he was setting down programs of translational immunology in a time, again, where basically immunology was almost unknown, human immunology. So he carried studies of immune pathogenesis and clinical immunology with patients' recruitments. In particular, Dr. Fauci set the standards for immunosuppressive therapies of systemic and life-threatening autoimmune therapies with the new protocols that are still adopted today. Nowadays, if you are an immunologist and you are experiencing like a life-threatening flare of an autoimmune diseases, I'm thinking of lupus nephritis, vasculitis, Wegener, you know as an immunologist that like the best shot you have to have remissions of that flare is through injections of high dose of cyclophosphamide. Guess what? There was an observations done 50 years ago on these issues of New England Journal of Medicine in December 71. Then the third Fauci started, the physician scientist looking and establishing program of public health. And this started in the early 80s, as you can see here, and went all the way through our days, which means 40 years on the edge as a reference for generations of doctors and scientists. Now, the initial trigger of this third life of Dr. Fauci has a precise date, which is June the 5th of 1981. When on the desk of Dr. Fauci, there was this weekly report from CDC on morbidity and mortality. And this report was reporting an unusual frequency of a rare skin tumor, Kaposi sarcoma, and a relatively rare opportunistic infections of the lung, the pneumocystic pneumonia, among homosexual men. This live CDC report was just following of 3 weeks, the first news released on this gay newspaper in New York, which was basically saying the same thing. And quoting is a public interview at the American Association of Immunologists, he said, and I remember sitting there in my office saying, oh my goodness, this is a brand new disease. Of course, we are talking about HIV pandemics, as you already realized. So from the early 80s, Dr. Fauci completely switched the gears in his research programs by fully devoting himself in the 80s and the 90s to study HIV pathogenesis and its impact on public health, as this new disease covered both infectious diseases and clinical experimental immunologists that represents the main scientific interest of Dr. Fauci, and has a deep impact on people and social health, thus allowing him to finally adopt a scientific methodology to solve problem of humanities. It was the interview, if you remember, of the very beginning at high school. So how did Dr. Fauci approach the HIV pandemic? First, starting as a physician scientist. This is like one of the first, I think it's the first important paper of Dr. Fauci about B-cell activations in AIDS. But he put together a team that was working day by day on immunology and AIDS. He put together a team that was studying the impact of viral replications on immune cells. And as you can see, we put together several people that are working day by day on this, and it was an active part of this job. But then he started also to develop public health programs. Why? Because the social burden of HIV/AIDS in the early 80s and 90s was really unprecedented. This is one of the very famous Fauci slides that show that although the first report of HIV/AIDS was like at the beginning of 80s in 1981, and the virus was discovered by François Balestudoucy and Robert Gallo in 83, the number of people living with AIDS was increasing year by year with no peaks, and we know descending slopes, as you can see, for years. But different from SARS CoV2 of this day, being infected by HIV in the early 80s and 90s represent a death sentence. As you can see, this is another famous Fauci slide in which you can see that starting from the 81 until 95, either without or with like the first drugs against HIV, the mortality rate was still keep increasing with no peak and no slopes, descending slope again. And only after 95, the initial advent of like a new therapy, the heart therapy, dropped the mortality basically very much. So back then in the 80s, there was a pressing and urgent necessity to develop public health programs and to put a brakes to the social plague and unmet clinical needs. So since then, Dr. Fauci devoted his personal professional life to this and started a long, fascinating journey. This photo is referred to the 30th anniversary of this journey. And here is the link. And really advise the medical students to see this link because it's very formative and it's one of the most great speech in public health programs. So to do so, in 1984, Fauci was appointed as NIAID Director, a position that still holds today. But to make all research and public health program possible, he was able to raise over the years of his tenure as NIAID Director the annual budget from $350 million to $5.9 billion, which is 20 times more, regardless of all the presidency and US Congress that he served as public institutions. To give you an idea how remarkable this is, I'm listing here the 10 richest countries in the world as GDP that cover head-on the 70% of the world GDP. Now, if you go at the very bottom of this list, you can also see that there are 40 countries in the world that have a GDP lower than 6 billion. And as you can imagine, these countries are confined within sub-Saharan Africa, Southeast Asia, and Central and South America. Now, on every year, NIAID is annually budgeting for medical research, including public health programs, financial resource higher than the GDPs of 40 countries in the world. So it's really remarkable. So thanks to all this very good amount of money, the achievement of Dr. Fauci in the creations and management of public health programs to fight HIV are very many, but not only US, but especially in developing countries. Here in this map, you can see the different public health programs developed by NIAID together with European Agency and WHO. And there are very many. And there was a very good strategy because although some of those, like the vaccine trials, basically failed in HIV, other programs like prevention of sexual transmissions, prevention to mother to child transmissions, access for treatment to everyone in the world, or the pre-exposure prophylaxis were very successful. And as you can see from these epidemiology curves, here on the left side, you see like the ones in the US. As you can see that by the end of 2010, the mortality of AIDS in Western countries, and this US is a representative example, basically dropped to zero. And even the new infections was very low. But most remarkably, this was happening also in developing countries. Here you have, like on your right side, the example of Zimbabwe, in which even there, in countries where there is basically a very unstructured public health system and there are no at all public health programs, these slopes were starting to descending. So from then on, of course, Fauci went on in developing public health programs. Of course, SARS-2, which is the reason, as Andrea was saying before, for which most of you got to know Dr. Fauci. But SARS-2 means, of course, that we were a SARS-1. So at the first epidemic outbreak of SARS-1, that although was very limited, and it was in 2002, was very informative because back then we did not even know the name of pathogens with the first patients. So the public health programs allow basically to discover that was a coronavirus and all the different pathogenic mechanisms that was immediately used to study the second pandemic we are experiencing now. But this is not the only crisis that NIAID through Fauci was basically facing through these years. Indeed, remember that at the beginning of this century, there was first the anthrax, in which the bioterrorism was basically sending powder of anthrax in the envelope letters. But also the zoonosis and the avian flu, swine flu in 2008 and 2009, without considering the 3 outbreaks of Ebola hemorrhagic fever in Africa. Then the Zika came in 2015, without not even considering the annual flu outbreaks. So as you can see, these all are infectious disease crises that basically hit the society over the past 2 decades. And NIAID was always on the edge in dealing with them. And then I would like to finish this this presentation introductions with the fourth Fauci, a pioneer always in social communications, even much earlier than the advent of Facebook, Twitter, Instagram, and so on. Indeed, when we were going in the hospital or we were going in the lab, and we were almost close to finish a project or writing a papers, he was always repeating, you must be able to wrap up your science and deliver it worldwide in a way that everyone can understand. There was a mantra of Dr. Fauci. Indeed, he was saying that you must having a science product in your pocket that is worth Nobel Prize, but if you're not able to disseminate it, it's worth nothing. So that's because for him, disseminations and communications, it's as important as science. Sometimes it's even more important than science. And indeed, the NIAID is a team. that organize like disseminations. And it does at 4 levels. The first level is scientific community. So when you prepare a talk, a symposium, a meeting, a paper, this is although very difficult because it is indeed difficult to like simplify the complex pathogenic diseases, the pathogenic mechanism of the disease. But at the end of the day, it's the easiest because you are talking to your own community. So you don't have to invent nothing. The second level is the activist. Now, the activists are the most challenging for him because the activists are people that know, or at least pretend to know, everything about the disease, the scientific or like social issue they are fighting for. But a lot of time they go too extreme. You are absolutely aware that Dr. Fauci received recently quite a lot of threats, very, very dangerous threats that forced him to take protections from the US government. But Dr. Fauci is not new to these threats. Even at the time of HIV pandemics, he received a lot of protest against him and a lot of threats. And even some like press journalists, like the one like Mr. Kramer for the San Francisco Examiner, basically called him an incompetent idiot. So how Dr. Fauci replied to this? By simply disseminating, communicating, and speaking. He's really believing in this. As you can see in these slides on your left sides, this is like the International AIDS meeting where the scientists convene every year, every 2 years. Now you can see Dr. Fauci with François Barré-Sinoussi basically surrounded by activists, which are the same activists that basically were fighting against him, because you like to explain them like how the science works. Or it meets also patients. This patient is a patient, this girl recovered from Ebola hemorrhagic fever, and now he is starting use like platform like Instagram, Twitter, and Facebook. The third level of communications is the official institutional communications. Indeed, it's extremely important to talk to politicians to acquire financial support and approval. And as you know, Fauci served 6 American presidents, from Ronald Reagan to George Bush father, to Clinton administrations, to Bush son, to Barack Obama and Donald Trump. And I would like to drag your attention on the Bill administration slides, as you can see here. There was a time in which not even the PowerPoint presentation were implemented. And he was basically printing these slides, taking the slides with him, and explaining with like a manual pointer to President Bill Clinton and Vice President Al Gore how HIV was getting into a cell. So that was like the level of communications he was setting back then. And of course, he served U.S. Congress and all like the government and intergovernmental administrations like FDA, CDC, WHO, European Agency. And then the last one, the society and the media. This is for sure the most difficult. Now, to give you an idea how to deal with this, I would like to finish with this video. This video is Dr. Fauci basically challenged by this anchor woman, Laura Ingraham, which one of the most famous journalists like in the US, which basically work at this Fox, a very conservative broadcasting, which basically was challenging Fauci with the real necessity of taking very strong measures against HIV. Just listen, please, to this video. It's very, very short.
We don't have a vaccine for SARS. I mean, they got close in mice. We don't have a vaccine for HIV, and life did go on, right? So the idea that we're definitely going to have a vaccine, we didn't really approach much else in the same way as we're pegging going back to normal with a vaccine, did we?
Well, but Laura, this is different. HIV/AIDS is entirely different. We don't have a vaccine for HIV/AIDS, but we have spectacularly effective treatment. People who invariably would have died years ago right now are leading essentially normal lives. SARS is a different story. SARS disappeared. We developed a vaccine. We were in the process of going through these phases. We showed it was safe. We showed it induced a good response, and then SARS disappeared, and we didn't need to develop a vaccine for SARS. So I think it's a little bit misleading maybe to compare what we're going through now with HIV or SARS. They're really different.
But we don't know. This could disappear. I mean, SARS did pretty much disappear. This could as well, correct?
Yeah. You know, anything could, Laura, but I have to tell you, the degree of efficiency of transmissibility of this is really unprecedented in anything that I've seen. It's an extraordinarily efficient virus in transmitting from one person to another.
So I think this video is really self-explanatory on how to deal with science and how basically it deals with no sense. So I hope I gave you in these introductions the reasons by which the multiple lives of Dr. Fauci trained generations of physicians and scientists worldwide, and why they remarkably helped the mankind to improve its health status with pioneer and visionary programs of translational medicine and public health programs. Because at the end of the day, the motto of Dr. Fauci is trust science to improve public health for the society to grow. So, and with this, I would like to ask the LT guy to basically upload the presentation of Dr. Fauci. Thank you. Okay, here it is.
Buongiorno, colleghi e amici. My name is Tony Fauci, and it is my great pleasure to speak at this academic seminar entitled SARS CoV2 Vaccine Development as part of the Virgilio program, Excellence in Research Track. I also want to thank you for all your good work, especially during these very difficult times of this historic pandemic. As you can see from this first slide, I'm going to be speaking about both the public health and scientific challenges, including vaccines associated with COVID-19. I thought I'd give you a broad overview to put into the context of what the theme of the meeting is. In January of 2020, my colleagues and I wrote a viewpoint in the Journal of the American Medical Association, which I chose to entitle Coronavirus Infections More Than Just the Common Cold. I did not mean to be facetious by this because I wanted to point out to the readers of the viewpoint that we have had extensive experience with coronaviruses over decades and decades. The human coronaviruses are shown in the red lettering. Among those are 4 coronaviruses that account for the common cold, 15 to 30% of all the common colds that we experience repetitively, usually during the winter. Note also that there are bat coronaviruses that fall within the same phylogenetic proximity to that of the human coronaviruses. This is obviously relevant in the jumping of species from a bat to a human. However, in 2002 and then in 2012, we were met with the first, at least to our knowledge, the first pandemic coronaviruses. SARS, the original SARS, came in 2002 from a bat to a civet cat to a human in China, which led to an outbreak of 8,000 cases and close to 800 deaths. Due to the lack of very high efficiency and transmissibility, this virus was actually eliminated by pure public health measures. In 2012, again, jumping of species from a bat to a camel to a human in the Middle East and Saudi Arabia, another pandemic not nearly as extensive as SARS. And in fact, there are still reintroductions into the human species, even as we speak today. So fast forward to today, we now have the third pandemic coronavirus that originated in the Wuhan district of China in December of 2019 and was first identified as a novel coronavirus in the first week of January of 2020. That is the background. Fast forward to where we are today, and we have now SARS coronavirus 2. As you can see, its proximity as a beta coronavirus phylogenetically, the nomenclature was changed so that the original SARS is called SARS-CoV-1, whereas now what we're dealing with is SARS-CoV-2. The disease that it causes is COVID disease 2019, hence referred to as COVID-19. And as I mentioned, the virus is now named SARS-CoV-2. So where are we with that right now? Today, this has emerged and exploded into one of the most challenging pandemics in our lifetime and beyond. This is the worst affront to the human species with a respiratory-borne pandemic in 102 years, with over 55 million cases worldwide and about 1.4 million deaths. The United States of America is the country that is hit most hardest. As of literally the 17th of November, we have now 11 million cases and over 245,000 deaths. The density shown in the various states in the country are shown by this heat map, with the darker areas now being the most intense. This is a reflection of the last 6 months, which has happened. Go to the right-hand bottom side where it said 6 months ago, then 5 months ago, 4, 3, 2, 1, and now we, as similar to what our European colleagues are seeing, are having a massive surge of cases that surpasses anything we had in the spring. If one looks at the difference between what happened in Italy and what happened in the United States, we both had surges of cases. First, Italy, a few weeks before us, and then Italian travelers likely seeded it in New York City, which had a major burst shown in red. The difference is that when you got your northern Italy outbreak under control, you came down to a very nice baseline, which stayed very low. Whereas the United States in red never got to a good baseline. We tried to reopen the economy in June, and as you can see, the cases soared up because we did it in an inconsistent manner, with different states doing it differently, some not paying attention to the guidelines that we published. We got it a bit under control, and then as the cooler weather came in the fall, and as COVID fatigue set in, both the United States and Europe, including Italy, began to surge, which is what we are seeing right now. The numbers in the United States are stunning. Over 150,000 cases per day, over 1,000 deaths. Thus far, we now have hospitalizations to the tune of 70,000 people in the hospital for COVID-19. The 7-day rolling average in Italy from January 1st to November 17th are shown here, essentially emphasizing with a single graph what Italy has experienced and is experiencing. I'm encouraged by a bit of the plateauing that we're seeing now as we're well into November, and hopefully that plateau will maintain and rapidly start coming down. However, we need, obviously, to maintain a high degree of public health measures. Moving on quickly to the virology. As I mentioned, this is a beta coronavirus, an RNA virus. It has multiple structural genes, the most important of which is the spike protein shown on the right-hand side, which binds through its receptor binding domain to the ACE2 receptor seen on multiple tissues of the upper lower airway, as well as the GI tract and other tissues, including the heart. Transmission, this is a respiratory-borne virus with transmission both by classic respiratory droplets, which tend to drop within 6 feet, as well as some degree of aerosol spread, namely droplets small enough that they remain in the air for periods of time ranging from seconds to minutes or even longer. Virus is found in a number of body fluids, but it is unclear and likely not an important method of transmissibility among individuals. The risk of transmission varies depending upon the type and the duration of exposure, usually in congregate or healthcare settings, particularly when people are not wearing proper personal protective equipment. We have seen outbreaks in cruise ships, nursing homes, and in prisons. Crowded enclosed spaces with poor ventilation are important factors. It is not just coughing and sneezing, but singing, speaking, or even breathing heavily can transmit the virus. The fundamental principles that prevent acquisition, and transmission are 5. 1, universal wearing of masks. 2, maintaining physical distance at least 6 feet apart, avoiding crowds and congregate settings, outdoor much better than indoor, and frequent washing of hands. One of the very unusual aspects of this infection is that about 40 to 50%, 45% of individuals are infected and have no symptoms. This leads to a very problematic asymptomatic community spread. And in fact, modeling studies show that approximately 50% of transmissions are from an asymptomatic person to a person who is uninfected. The clinical manifestations are protean. Early on, the symptoms resemble very much a flu-like syndrome, as shown on this slide, with fever, cough, fatigue, myalgias. However, a certain percentage of individuals have a very unusual and interesting loss of smell and taste preceding the onset of respiratory symptoms. Even among those who have symptoms, about 80% are mild, whereas 15 to 20% are either severe or critical, giving a case fatality rate of a few percent up to as high as 20 to 25% among individuals on ventilators. That case fatality rate is referring to people with severe and or critical disease. People who are at increased risk for this severe disease are older adults. As shown on this slide, a striking difference when you look at the rate of hospitalization per 100,000 cases. What you see here, 100,000 population, you see a minimal amount of hospitalizations among young people, whereas that increases dramatically as we get to the elderly. In addition, people of any age with certain underlying medical conditions. What are those conditions? Those that are clearly associated with a risk for severe disease are predominantly obesity, chronic obstructive pulmonary disease, diabetes, and heart conditions. There are other conditions that are less likely, but nonetheless significantly associated with severe illness. And that is, again, overweight, but not by definition obese, diabetes, hypertension, and the immunocompromised state. The manifestations of severe disease are dominated by the acute respiratory distress syndrome, but there's also cardiac dysfunction with cardiomyopathy, arrhythmias, often leading to sudden death, kidney injury, neurological disease, but also a very peculiar hypercoagulable state with microthrombi in small vessels and thromboembolic phenomenon in larger vessels, leading sometimes to acute stroke, even in otherwise apparently normal individuals. There's a curious syndrome in children called multi-system inflammatory syndrome, which resembles Kawasaki's syndrome, which is also a very unusual syndrome in children. Individuals who have been affected, who have been ill, not necessarily in the hospital, but who have had substantial symptoms, either as outpatients, inpatients, or even in the intensive care unit, when they recover virologically, in other words, when there are very few symptoms that they have from the standpoint of the virus itself, or very little laboratory evidence of persistence of virus, they have persistence of other types of symptoms that are generally characterized by very severe fatigue, shortness of breath, muscle aches, dysautonomia, or temperature control difficulties. And some even talk about a brain fog or an inability to concentrate or focus. We are doing a major study about this in the United States. We're trying to find out what percentage of people have this post-COVID syndrome and what, if any, are physiological phenomenon that can be related to the cause of the syndrome? We do not know the answer to that. Hopefully, we will find out. Moving on to therapeutics. The United States has put together at the NIH a treatment guideline panel, which is a living document to be accessed online at the site shown on the slide with the red dot. What it is a number of experienced clinicians who put up to date on the living document not only published studies, but also expert opinion on the management and clinical treatment of individuals with COVID-19. 2 interventions have already been recommended, remdesivir and dexamethasone. I'll get back to that in a moment. What we definitely need are interventions to be given early on to prevent individuals from having to get into the hospital. These are direct antivirals, convalescent plasma, monoclonal antibodies, immunomodulators, or what have you. All of these are in intensive clinical trial. Remdesivir has recently been reported in the final report in the New England Journal of Medicine. It has been shown in people who are hospitalized with lung involvement to significantly diminish the time to recovery. It has, in fact, just a few weeks ago, been the first COVID drug to receive FDA approval. Dexamethasone, a commonly used anti-inflammatory agent, has been shown to diminish in a randomized placebo-controlled trial the 28-day mortality on patients on ventilators or requiring high-flow oxygen. There has been a monoclonal antibody that has been used in mild to moderate COVID-19. It was developed in collaboration with the NIAID Vaccine Research Center and is now available as an emergency use authorization. Finally, vaccines, obviously a very important tool in the armamentarium against COVID-19. The United States has taken a strategic approach to COVID-19 vaccine. This is a description of that written by my colleagues and I in Science in May of this year. By strategic approach, we mean supporting either the development of or facilitation of the testing of 6 vaccines with a common data and safety monitoring board, common primary and secondary endpoints, and common immunological phenomenons. In other words, what we're doing is we're having a coordinated protocol. These are the 3 platforms and multiple developers and the status of the clinical trial. We have nucleic acid with mRNA by Moderna and Pfizer. We'll get to that in a moment. Viral vector with AstraZeneca with the chimp ad, Janssen with the ad26 human, and Merck with the VSV, and protein subunits with Novavax and Sanofi. 5 of these are in various stages of trial, usually phase 3. 2 of them have been fully enrolled, and we have information on them, which is very exciting. If you look at how long it took to go from the sequence that was given publicly to the time the Vaccine Research Center went into partnership with the mRNA from Moderna, it was 5 days. Within 2 months, we were in phase 1 trial, the fastest ever done for a new pathogen. Within 139 days, phase 2, and within about 6 months, a phase 3 trial, which began on July 27th, together with the Pfizer trial, which began on July 27th. Both of these have completed, and their results are as follows. The Pfizer trial on Monday, November the 9th, showed an efficacy of greater than 90%, truly an outstanding success. 1 week later, the Moderna trial showed an efficacy of 94.5% in an interim analysis. Both of these right now are being submitted to the FDA for an emergency use authorization, and we should start to be vaccinating the highest risk individuals by the end of December of this year and the beginning of November of next year. With regard to vaccine distribution, the CDC makes that final decision in association with the Advisory Committee on Immunization Practices. The suggestion, even though the final decision has not been made, is that high-risk healthcare workers and first responders, as well as older individuals, particularly those in nursing home with high-risk comorbid conditions, teachers, school staff, child care workers, individuals who are risk but essential industries, homeless shelter groups, other older individuals, and then members of the population who are generally normal with not underlying conditions. Again, this is just a framework of suggestion. The final decision will be made by the CDC in association with the Advisory Committee on Immunization Practices. We have a problem in the United States that there is an anti-vax feeling and individuals are reluctant to or do not want to get the vaccine. Note on the bottom of the slide, this is especially true of our minority populations, African Americans and Hispanics. So we must reach out to them to convince them of the importance individually and for society for us to vaccinate, particularly since we have such a highly effective vaccine. I want to close with this slide that is now essentially telling us that we have been hit with 3 coronaviruses that have been pandemics. It is absolutely essential that looking forward, we begin the work on a universal corona vaccine because we will be challenged again by this virus as it jumps species from an animal to the human, similar to how we must develop a universal influenza vaccine, because these challenges will be perpetual and our preparation must be perpetual. So thank you again for giving me the opportunity to make this presentation. I want to greet again all my friends and colleagues in Italy, and thank you very much for this opportunity.
We open the platform for the question and answers now. As I said before, when you write your question, please address it to all panelists. Select the option all panelists. Thank you.
Okay. Okay, I want to first address a statement of one of the participants that say that so we can say that SARS viruses did not disappear, unlike this was stated from Dr. Maviglio. Oh, I'm sorry if I was misleading. I didn't say that SARS disappeared. I said that the SARS-1, as Dr. Fauci also said in his presentations, as well as the second outbreak, the MERS, the one in Middle East, were caused always by coronavirus. But those viruses are different from the one that we have now. So those outbreaks in 2002 and 2015, if I remember well, basically were self-limited. And that outbreak never became a pandemic, but was epidemic outbreak. So the one that we have now, the SARS CoV2 pandemic, of course, it's a different virus and it's not disappeared at all, of course. Now, that's one question. I'm sorry, I'm going to the questions. What are the major side effects that have been observed with vaccine trials, if any? So the full results of like the two vaccine trials, the one from Pfizer and the one from Moderna, which are the one that basically are close to be completed in trial 3, are not over yet. And there was like only a side effect reported like by the press by a few weeks ago from the AstraZeneca one, which is not even the one that is basically is going to be finished earlier. So when the data will be available, we'll be able to understand if any side effects, if any major side effects is available on this. So far, we don't have information on that. I'm going through the questions. Okay. In Italy, what is the plan? I'm sorry, they're going so fast that as soon as I read one, the other one disappeared. Okay. Okay, they're going very fast, so I'm not able to read the questions that like to get a response because they go to the following questions. They're very fast. I'm sorry. I'm trying to stop. Okay. In Italy, what is the plan for general population's vaccinations? So as an official plan has not been released, as far as I know so far. I know they are working on this on the Italian Ministry of Health, but like I guess like a plan could be like very similar to what that like Dr. Fauci showed you in the presentations that is basically now under the final approval from like CDC and the Health Department of US. Do we know what is the fundamental difference between the Moderna Pfizer vaccine? Why does one need to be stored in so much colder condition than other as they're both mRNA basis? So that's another important question, especially for logistics and distributions of vaccine. They are both mRNA vaccine, but they are done like in different ways. So one is more stable, the Moderna at below 20 degrees. The other, the Pfizer, is like needs to be stored like a minus 70 for really technical reasons. And as at least like what Moderna said, the Moderna one could be also be stable for 24 hours and like normal temperature. So there are technical based issues that will for sure affect the distribution and logistics of this vaccine. So let's keep going. In what group should we expect med students like us to follow in regard the timing of distributions of vaccine? So again, this will depend from like the decisions, the logistic of the Italian Ministry of Health and Istituto Superiore di Sanità. But I guess since like the medical students are much more exposed, we'll be getting like into the first classes, but we don't know yet. Are there any concern about possible long-term effect of the vaccine? So that's another important question. And there are like a lot of discussions about this. Indeed, like more people, quite a few people are like kind of concerned about the speed of the approval of this vaccine in the phase 3. Are not approved yet, but like all the data are now released by the manufacturer of the vaccine, so Pfizer and Moderna. And Pfizer just submitted like the request to get approval from the FDA. So all this data will be examined by FDA in the US on the European Medical Agency Europe, EMA. So only after their approval, the vaccine will go basically in distributions. So they will see if there is any major effect or any minor side effect. And if there are any, the vaccine will not be approved. So only after the approvals of this regulatory agency, we're going to know like about possible side effects that so far are not like being reviewed by them. Buongiorno a tutti, grazie. Okay, there's like a questions in Italians, but he actually asking what are the long-term effect of the coronavirus. That's a very another important questions. I will start saying that like all these patients that we know, like it's about like in Western country, it's about 10 months old. So we don't know what's going to happen like in the long term, of course. So, and there's like very important studies that are started both like in Europe and US, as Dr. Fauci was also saying in the presentations. So far, what we know that like in the long term, like the oldest patients, and by oldest I mean patients that they are like 9 or 10 months old, they recovered like 10 months ago, they have this like foggy brain, so this inability to concentrate, or they have fatigue, asthenia, so very general symptom. So we will need a really long time if to know if a really chronic COVID symptomatology exists and it's stable. So the time is too short yet to know about like the chronic effect of COVID. Good morning. Can vaccinated people stop worrying about COVID-19? Oh, that's a question that I think also Professor Mantovani will address later. And it's regards about like how long the immunity lasts after like the vaccinations or even after like, getting the disease. The answer is we don't know. Simply for the same reasons of before, because like the oldest patients we have is only 10 months old. So we don't know what's going to last and how like the vaccine is going to protect how long. So for like the first trials, we are expecting to get like 2 shots of doses, the first and the second one after a few weeks. So we hope that this will get like longer protections, but like we are only assuming so far. We have no data about like the possible like vaccine, possible protection, the timing of possible protections. So what about the long-term adverse effect vaccine may use? So the questions are always going in the same direction. So again, the vaccine are still now in the phase 3 trials. So we have to wait. The FDA and EMA and IFA in Italy going to see like all the paperwork, all the procedure of the phase 3 trials, and then let's see which kind of, if any, side adverse are caused, and then we'll see. But we don't know what are the long-term adverse of this, because we don't even know what's basically will be like the short term. As far as I understand, a main concern in vaccine development is the persistence of the immunity conferred by vaccinations. Do we have tools to predict how long will the immunity conferred by recent approved vaccine last? Again, the question is going in the same directions. I would like to point out, like in this regard, that of course we are looking and neutralizing antibodies, as Dr. Fauci said. But like a lot of study, we are also needed to see, like the cellular immunity and how long the cellular immunity will last. We know, and there are like a few publications also like already came out, that a T cells immunity is indeed occurring in these patients, but how long it will last, and if a T cell immunity it will be able to protect the patients regardless of the drop of neutralizing antibody is still not known. So we need like to investigate more on like a larger cohort of patients. Are there any pathological evidence for the so-called foggy brain symptoms? As I told before, the evidence are like the incapacity to concentrate, for like the foggy brain, the fatigue, the really increasing dyspnea and difficult to breathe. So they are very, very general symptoms. And those so far, these are the symptoms that have been associated with like the so-called foggy brain syndrome or like chronic, but it's again need to be seen like in a longer term. How is the effectiveness of phase 3 trials confirmed? So that's another important question, but it goes in the same directions. So far, like the statement of both the 2 main trials coming almost to an end are from Pfizer and Moderna CEO. So they are done by the company themselves. Of course, we don't have any like reasons to doubt about like the statement, but the statement done by the company. So the effectiveness of the phase 3 trials must be approved by independent regulatory agency. They don't basically give any credit to anyone, to NIAID, to European governments, but they are just independent. So FDA, EMA, IFA, on their own, without any connections with like the companies, they review all the procedures and the paperwork of the phase 3 trials, and they approve independently. So only after their approval, So we can basically have more reliable data about the effectiveness of the phase 3 trials. So far, we have also only declarations from the CEO. We don't have any doubts, and the data looks good, but so far, it's not enough to make the vaccine on distribution. I would like to ask why in convalescent there's a tendency that antibodies are going to disappear, and this is scattered with the new vaccine. Again, this is like questions going in the same directions. We don't know. So there is not enough information to see why in some patients the titer of antibodies increase even after recovering, or like in others decrease during convalescence. Again, we need to better dissect and to better dig into the immunopathogenesis of this disease. How often should the vaccine be administered, considering how long the antibodies stay in the body? That's a very, very important question. So far, as I told you, there are like 2 doses of vaccine. They are like schedules for at least for Pfizer protocols. But this is like absolutely independent so far of like the titer of antibody in the body. So it's a protocols, and we'll see if the protocols will be adjusted, adapted, but we need to know much more about the clinical history of the patients. And again, the oldest patients we have in our hand recovered is like only of 10 months. After people get vaccine, how much can we trust the effectiveness of vaccine? Yeah, this is always a repeated answer to this. And after getting vaccine, the lives come back to normal before COVID. We hope so, of course, that vaccine is effective, as is effective, for example, on like animal models. What about the normality? We want, of course, go to normality, every one of us. Of course, the more people get the vaccine, the more people are protected, the higher the virus is confined. So that is basically the biggest statement. So if like the majority of populations will get the vaccine, the virus itself will stop, because all the majority of the people will be protected, and so they will not be any more carrier infections for new people. So like the deal here is to get the vaccinations like to the largest amount of populations like worldwide. And this basically will make hampering the virus ability to go from a human to another human. So, and it's a very important logistic and distribution issues that must be taken by all the governments in the world. Will it be possible to vaccinate only high-risk subjects and rely on herd immunity for low-risk subjects? It's a very risky bet, because the problem that even though like asymptomatic people or low-risk people are infected, they still are able to spread the infection. So they are still a threat for the society. So I wouldn't go in that directions. And I would go in directions that like to several risk of like severities, all the populations get vaccines. Will vaccination start before in the US or both in the US and Europe at the same time? The 2 trials, the Pfizer and the Moderna, are US companies. And of course, they are looking and they are following the approval rate from the FDA in the US. Of course, the European approval, it does not depend from FDA, but depends from EMA. But I'm sure they were rushing as well. So probably the US will start a little earlier, but not that much, but it depends only by the administration, the different administrations of regulatory agency. But like they are working hard on this together, and I think like they will start the vaccine, like if not together, like with a very different timing. But again, this is logistic and organizations. Is the risk stratifications for different phases of vaccinations going to be done by family physicians, or are there a many efficient way of doing it? Or that's not a question that, I can address, because the logistic, it's amazing. If you think like about like the different infrastructures, one virus below one vaccine require minus 70, one other minus 20, the hospital, the public vaccine centers all around the world. It's really a huge logistic issues. And that's only like different governments of the world can address these questions by organizing like a very capillary delivery system. when the vaccine will be out, how much time the pandemic will be declared finished? Hopefully soon, but it's like, $100 million questions. It's really impossible to answer that questions. How does an mRNA vaccine work? It's basically mRNA, like the mRNA vaccine are from Pfizer, from Moderna. They are two vaccines with the nucleic acid. Basically, they inject the mRNA for like the spike protein of the virus. If you remember the very beginning of the presentation of Dr. Fauci, in which they described the virus, the spike of the virus is the one that is basically attaching the receptor, ACE2 receptor, on the mostly epithelial cells of the higher and lower respiratory tract. So mRNA basically codify for the spike. So we inject like a human, and we use like the immune system of vaccinated people to recreate antibody against like the spike, because we inject mRNA of the spike. And so basically the strategy of the vaccine is basically to inject mRNA of the spike that will become then the spike of the virus, and then will be the immune system of the vaccinated people, vaccinated men, to basically produce antibody against these spikes and then against the virus, thus basically not allowing to the virus, blocking the virus for getting into the cells. What is the current data suggesting in the reinfections people who have already recovered? That's another big important questions. Again, we don't have enough data to see if like the rate of reinfections in people that get the first infections are high, because the number fortunately are still very low so far, but we need more time to understand how long the immunity lasts in the patients. Okay, so far the majority of the people doesn't get reinfections, fortunately. And that's because even the vaccine trials started with 2 shots of vaccine. But the question is always, this question is really the same issues. How long the immunity will last? And the answer is we do not know so far. Another question, some study reported the limited persistence of the antibodies after the disease. Will be a vaccine really efficient if the antibodies are not able to remain? Could the vaccine give a longer immunological memory? So again, that's depend of how long a cellular immunity will last into the vaccine patients. Now, if you take a book of medicine, you know that like viral infections usually first develop like cellular immunity, and then cellular immunity, of course, go against adaptive immunity and productions of antibodies. So as far as we will know how long like cell and cellular immunity and antibodies immunity will last, then we'll have the answer to your questions. But again, we don't even know for normal infections figure for the vaccine. Do we know why the SARS CoV2 is different from other coronavirus? That is why it's so easily transmitted. So this is like another important questions, and the answer was partially different, partially explained by the first slides of Dr. Fauci, in which he showed like the phylogenesis of the virus. Because you can see that the virus or the viral outbreak of 2002 is phylogenetically different from the one that we have now, and also from the one that we have in Middle East. This is because the virus evolved according to the host. And they do like a natural selections to be, of course, able to survive, because the only things that the virus wants to do is survive, because it's a parasite, not able to live by itself without a host. So it's simply viral evolutions, and we can track the viral evolutions by the phylogenesis. And that's how we know that this SARS CoV2 is much different from SARS-CoV1, and this difference is also associated with a high contagiosity. How old the vaccine is administered, we already got that. IgD decline could be the response to vaccine, we already got that. The Pfizer Moderna vaccine are either mRNA vaccine, no, they are mRNA with nucleic acid vaccine. There are other vaccines on the pipeline, For example, the one from the Oxford vaccine, the one from AstraZeneca is done with adenovirus carrying the spike, carrying the DNA of the spike and so on. But the Pfizer and Moderna are with the nucleic acid vaccine, so with mRNA. As the safety of this vaccine has been tested on the patients most at risk, so there are several protocols, and the vaccine has been tested on several several age, several risk category. And again, as soon as the regulatory agency will revise the paperwork of phase 3, we'll know if any major effect is being observed. So far, the manufacturing, so the Pfizer and the Moderna didn't announce any major side effect in such, even in elderly. There have been a few cases of infections. We already got that. Are there any pathological evidence for so-called foggy brain syndrome? We already got that. Also in Italy, there's a strong no-vax movement. Are there any concrete measures that could motivate people to vaccinate? Is it possible to make the vaccinations compulsory, or are there big ethical issues about this? That's, I guess, it's the biggest questions. It was also addressed by Dr. Fauci in his presentations. So I don't think that the vaccine will be mandatory or compulsory for the populations. I don't think the government will do that. I don't think it's ethical as well for quite a few reasons. But the only possibility that we have people get vaccine is to explain them. To explain them and to talk with them, because at the end, if you explain people why this is important, only a minority will still be resistant, as Dr. Fauci also show in his vaccinations and in his presentations. And the no-vax movement, it's not an Italian problem, but it's a world problem for sure. In an effort as to convince the largest amount of people to get the vaccine, when available, how dangerous are some statements to express? How dangerous are some statements that express doubts against vaccinations from highly regarded scientists? I don't think I can address this question as well because it's out of my competence. What may say science concretely do reduce the conspiratorial evidence against corona vaccine? Again, I don't know. Which are the factors involved in the present healthy patients with the severity of the clinical presentations? Again, it was very clear from the presentation of Dr. Fauci, the comorbidities that are really affecting the severity of the disease are cardiometabolic disease, obesity, age, diabetes, the comorbidities that were shown very clear in slides. Is there a major difference in the criteria of vaccine approval between FDA and European agencies? There are several protocols. The protocols are not that different, but the two agencies are they are talking to each other, but they are independent agencies. What about the temporary immunization that this vaccine provides? I read that this is prescribed about around 6 months. It's not proved. Again, we don't know. Why do you think that after such a short period of time, not only but 5 or 6 vaccines appear in the same month? Mine is not a conspiracy theory, but doesn't sound strange to you. Again, I don't know what to answer to this. Why in the USA, where the social distance between measures have been weaker, the mortality rate is similar to Europe? USA, it's a very, very heterogeneous country. So there are countries for example, New Jersey, which is very, very hardly hidden. Some other country like Vermont, it's very, very lightly hidden. So US is not Italy. US is a huge country with a lot of different social, cultural, weather. And so when you take the US epidemiology, you have then to see state by state what are the real situations. It's not like Italy, which is a much larger state. And even in Italy, there are differences we experienced in the first outbreak. What are the ethical concerns about first 3 experimentations? How is the first vaccine phase trials? So, as you know, the vaccine trials have the 3 major phases before going into distributions. The phase 1 and 2 are basically for toxicity, It's important that, there's no toxicity. And the phase 3 is basically based on the effectiveness starting from phase 2 on large recruitment of people. So the phase 3 is extremely important to see that whatever you're starting to see in the phase 2 is also available on large patient recruitment in phase 3. And it depends from the vaccine, of course. They check several parameters, including the appearance of antibody, of course. Are you at all concerned with the time frame in which vaccines are developed? Are there any implications? Again, I think I addressed this as well. So far we have but I will repeat, so far we have, of course, declarations of the manufacturers, so Pfizer and Moderna. Again, this will not impact at all in any terms the revisions of FDA and EMA and IFA. They're completely independent, so I don't have any concern that EMA, FDA can be anyhow influenced by the manufacturing statements. What we know that natural immunity of COVID-19 lasts for a short time, so people can get infected. I think I already got that. We have data about the fractions of the Italian population that isn't willing to get the vaccine. I really don't know. How we do counterbalance the effect to reach herd immunity. I don't know how many Italian Novax are existent. I'm sure it's a minority, because I'm sure all our citizens are very responsible and will get the vaccination. Dr. Fauci devoted a great part of his career to HIV pandemics. In public health, what are the current challenges related to SARS CoV2 and HIV? How did Dr. Fauci expose this previously experience with HIV to this different virus? I think I show you, in my introduction to Dr. Fauci, how did they approach public health in the early 80s with HIV pandemics. So thanks to that, they basically developed really programs of public health. Now they address to any emergency crisis that are occurring all around the world. As I show you in the slides, from Ebola to Zika to swine flu to MERS and to others. So there are precise procedures of preventions and public health programs that are basically learned by HIV pandemic experience for sure. How much of the long-term effect can be referred to organic lesions of the lungs, of much caused by the training? Oh, that's another very good question. So we don't know if severe respiratory distress or severe pneumonia will be giving chronic lesions of the lung or fibrosis of the lung. It's too early to say, okay? So we need to get the patients in 2, 3, 4 years from now to see if they will have, in years, any functional or anatomic defect that was directly related to their pneumonia caused by SARS CoV2. Will the SARS CoV2 to anti-flu vaccine? No, it's different, and I explained that before. Must there be a minimum threshold of population to be vaccinated in order to achieve herd immunity? So even for that, we don't have real number. But the large populations, some people say 70% of population, some people say 80%, some people say 50%. So it's, again, as Dr. Fauci said, it's the first time in 102 years that we got such a pandemic after the Asiatic in the beginning of last century. So we have really no data to see if the herd is 70, 80, or 90. But the rules is the largest is the amount of people vaccinated, the better it is. Do we know within how many months, years we are predicted to distribute is at not risk populations? That depends from the government distributions, from each single government. If it's not known how long the immunity given by the vaccine lasts, from a public health point of view, would it be risky to vaccinate people telling them that they are protected when actually it's not know how long protection is this? I think the major risk is the other way around. It's ethical, basically, not to protect people that are not protected now. So I guess that to stop the viral spread, it's mandatory to basically protect the people, because even asymptomatic people, and they represent up to 50 or 60% of populations in different countries, they spread the virus. So how ethical is basically to have these people not get vaccinating and spreading the virus in the populations? So if I revert the questions, you can see that you can appreciate that it's very important to stop giving the virus the possibility to replicate. What other disease can the same evanescence of neutralizing when other diseases show the same evanescence of neutralizing antibody titers as COVID-19 and how we deal with them? So it's very hard to compare so far COVID-19 immunity with other like diseases because we don't know almost nothing about protections of COVID-19. So any comparisons would be like, a risk comparison because it would not be true. We heard from Dr. Fauci that in the US there seems to be a large anti-vaccine mentally. Do you think this will be the same in Italy? I mean, again, this is a worldwide problem. Also in Italy, we have no vax group of people. How we do convince them? It's no vax. Okay, I think I already talked too much about no vax. Must there be a minimum threshold of populations? Again, I did that. I guess now the questions are repeating one by one another. So, and it's already 11:25. So if you agree, Andrea, we can now keep going for like Professor Mantovani session. Because I'm reading the questions and are still the same questions repeating over and over. What do you think, Alberto?
Yes, we could switch to Professor Mantovani's session. I request Professor Biondi to give a quick introduction about Professor Mantovani and then he starts. Thank you. Thank you, Professor Maviglio. That was quite an intense question and answer session.
Thank you very much. Thank you very much to everybody for having me. Thank you.
Thank you.
So, thank you very much, Domenico, because it was really a fantastic session. The one from Anthony and your presentation and your very, very intense question and answer session. So thank you again, Domenico. Now I'm very pleased to introduce the second speaker of this morning, and is Professor Mantovani, and his talk will deal with the COVID-19 and immunity, the little we know, the challenges ahead. Professor Mantovani is Emeritus Professor of Pathology at the University of Humanitas in Milano and the Scientific Director of the Istituto Clinico Humanitas as well. His field of research focus on the molecular mechanism of innate immunity and inflammation, and he has contributed in the advancement of knowledge in the field of immunology, formulating new paradigm on cancer immunity and identifying new relevant molecules and function. Is one of the leading scientists in immunology in the world, and he has received many national and international awards. I don't list all of them because Professor Mantovani doesn't like too much this formal introduction, but I want just to mention the last one, which was one of the most important one, the American Association for Cancer Research International Pat Scholar Award for extraordinary achievement in cancer research. He has a broad impact in terms of contribution and scientific track records, and is the most cited Italian scientist with respect to citation and H-index. This is the formal introduction of Professor Mantovani, but I want just to end with few words, which is not formal, because I have the privilege to be one of many postdoctoral fellow who basically has the privilege since early 80 to be mentored by Professor Mantovani. And as a very young pediatrician, with no knowledge at all of lab and science, I've been approached and I've been the privilege to spend time in his lab, and starting from that experience, I have to say honestly, my life completely changed in terms of understanding what could have been the role of science and research. And I want to say a couple of words to say that Alberto was a fantastic mentor. And I really invite you to go and look for the Journal Immunity of 2017, which was basically dedicated to him and to his mentorship, and to read some of the paper that's been basically published by some of the people he mentored during his life career. I have the privilege as well to have a very close friendship with him, which is still continuing by now. And so I would like to thank again Alberto for being with us this morning and for the extraordinary opportunity I had in my life to be one of his mentors and to be one of his close friends still now. Thank you, Alberto.
Thank you. Am I visible now?
Yeah.
Yes.
Thank you, Andrea, and I would like to thank Andrea Biondi, Professor Biondi, Professor Maviglio, and the Virgilio program for the privilege to be here with you this morning. And if I may, I would like to say a couple of words of introduction. First of all, the Virgilio program. The four of us, Domenico, Andrea, Tony, and I, all of us are MDs. We are physician scientists, and I'm very worried that physician scientists are an endangered species. And Tony is a demonstration that we do need physician scientists. And the Virgilio program is an effort supported by Fondazione Cariplo, 3 universities together, and is an opportunity to provide MD students, medical students, to a chance, provide them with a chance to check whether they want to become people like Tony Fauci. The second, I would like to add something to the beautiful introduction made by Domenico of Tony Fauci. The first is autobiography. Of Tony Fauci, I remember an early review, Haningake and Fauci, on lung immunity. And and here we are faced with lung pathology to a large extent. The second comment is that I assume that many of you are medical students or MDs. Tony had recently an interview in British Medical Journal. And Tony said in this interview, on one specific point, he said, I was wrong. I was wrong. I mean, Tony Fauci, in a written interview, said, I was wrong. When I saw the new data, I changed my mind. I think that this is a lesson of humility. Data are data, and I wish many people in this epidemic apologize and change their mind. And I think that Tony set a fantastic example in that. Do read the interview. So now I'm going to share my screen. I assume you can see my screen.
Yes.
And assume I can start and record. So the focus of my presentation, of course, will be on immunity and the virus. I will repeat many of the things that have been said by Tony Fauci and by Domenico Maviglio. Let me just remind you that the immune system is a fantastic orchestra. And I'm still amazed by the fact that we don't know many of the players, we don't know many of the instruments, and in general, there are about 20-25% of the information in the genome that we don't know. So there is plenty of opportunity for you young scientists, you young physicians. There's plenty of opportunity for discovery. Immunity is a meta-narrative. This is our tenet, is a meta-narrative of modern medicine, in that inflammation, a manifestation of innate and adaptive immunity, is involved in a variety of disease states. And it bridges diverse things. Again, we were wrong here, see? This is David Foreman actually catalyzed this viewpoint in Nature Medicine recently. And we say here chronic inflammation. We should have said acute and chronic inflammation, and COVID is a lesson. Lifestyle, environment, inflammation bridging to diverse diseases. I mainly focused on cancer, but we heard about foggy brain, so central nervous system, cardiovascular pathology, and senescence in itself, because of a general paradigm of inflammaging, which was formulated here in Italy at the University of Bologna. So again, the tenet here is that inflammation is a meta-narrative of modern medicine, and we have seen this occurring in COVID-19. Macrophages are central players of chronic inflammation, smoldering chronic inflammation, or overt dramatic inflammations, such as the one that we see in acute respiratory distress syndrome. And if you are interested in a modern view of the role of macrophages in inflammation, Mihai Netea catalyzed the effort of a bunch of us, and here you have a small recap of the role of macrophages in inflammation. Let me remind you that these cells play fundamental role in under physiological conditions. In ontogenesis, you don't have a brain, you don't have a liver without macrophages, forging and paving the way and shaping the organ. It has physiological functions. I mean, this was totally unexpected for me. Again, the facilitation of discovery. Physiological function, for instance, in the heart. Branching morphogenesis, for instance, in the breast depends on macrophages. Metabolism is orchestrated by macrophages. And these cells are central in response to microbes, tissue damage, disease metabolism, adaptive immunity. And the general significance is that of first or second line resistance. And again, COVID-19 has shown that once more. Adaptive innate immunity, and we'll get back to that, and tissue repair. Plasticity is a hallmark of macrophages, and you get a classic activation, which was discovered many, many years ago. But then again, I assume I'm talking to medical students. In sepsis, you see parallel, a palsy of the system. And this corresponds to what we know as tolerance. And then there is something that is called trained immunity. This was originally observed in insects. Simon Gordon and I did some of the early experiments, and Mihai Netea has crystallized the concept, the name, fitness, immunological fitness in the innate immunity arm of the immune system. And so the basic tone of the first line of resistance. And this is based on epigenetic reshaping of cells, of myelomonocytic cells. And then we get to that. This is Vasily Kandinsky. I mean, plasticity is a hallmark of these cells. And again, I'm talking to the medical students. You should be prepared to change your idea. early on, we felt that macrophages in tumors are here, have an M2 phenotype in our jargon. But early on, the work done by Antonio Sica and Shubhra Biswas at the time in my lab has shown that these look like variations on this general theme. So plasticity, and this is Vasily Kandinsky showing plasticity, the capacity of the first line of resistance to adapt different conditions. As Andrea said, in addition to fundamental discoveries, my effort has been to translate to the tumor microenvironment the role of macrophages. I'm emphasizing because one of the messages that I would like to leave you with is that good quality research has across the board impact. One, the two vaccines that were discussed today, well, the focus, the hype on the media, the mRNA vaccines, one is stemming from cancer research. And I happen to be a good friend of Christoph Huber, and I happen to know Huber Sahin. They are cancer research people, and they come up with one of the first vaccines against COVID-19. And the Moderna vaccine has its roots, as was mentioned by Tony Fauci, at NIH. And Barney Graham, I mean, he was working on RSV mainly and flu. So we have been involved in the connection between inflammation and cancer, and relatively recently, we realized that there were not only cells, but there were components of the humoral arm of innate immunity, complement, and the molecule that we cloned, again, fundamental, the importance of fundamental research, that we cloned, actually a family of molecules that we cloned, distant relative of C-reactive protein, which all of us know as a diagnostic. So this is the background. Inflammation as a meta-narrative of modern medicine. First line of resistance, macrophages as being important. And now comes the virus. So this is the virus. This is not a picture of the virus as sophisticated as the one shown by Tony Fauci. This is the virus as seen by 3 of my grandchildren. But in essence, the message here is the spike protein, you can see. So we were confronted with a new challenge. We immediately realized that it was a serious danger, no flu-like bug. And so these are the roots of our Greek-Roman culture. And I immediately became aware that I didn't know. And I still feel that we don't know. I feel that we should share what we know. And this is an effort that we have been doing. If you want to know, I heard a number of questions about the vaccines. And if you want to know, understand the principles of the vaccines, you can have a look at the report by which was just out, the November report. This is outdated, I'm sorry. Is out of Accademia Nazionale dei Lincei. Guido Forni and I drafted the report with the help of many other people, including Lorenzo Moretta and Rino Rapoli and more. So this is a schematic representation of the virus, its interaction with human body, or here is the respiratory tract, and then with the immune system. And I'm going to go through it. Well, of course, we heard about the virus interacts, the receptor, the upper and lower respiratory tract. We do know now, I'm not a virologist, of course, but I need to understand a little bit about the virus as an immunologist. So we do know that the virus, of course, interacts with the respiratory tract. But in addition, we know that the virus interacts with the central nervous system. We heard about possible long-term consequences. And there is a recent paper in Science identifying the receptor that he used. It's neuropilin-1. In addition, the virus is present in the heart, in the kidney, but there is a paradox here. Namely, the dramatic inflammation is here, it's not in the heart, it's not in the kidney. Why is that? I don't know. The interaction of the virus with the host, the balance, is dictated by a number of factors. The viral load, of course, summertime, presumably less viral load. Aging, again, my friend in Bologna, inflammaging. And there is a general theory of aging whereby successful aging is dictated by the basal inflammatory tone. And this in turn is influenced by lifestyle. Obesity, we heard about obesity, we had a discussion and Domenico answered about obesity. And let me remind you that the fat tissue is made of immune cells and macrophages to a large extent, as many as half of the cells there. And when you are overweight and obese, they are set in a pro-inflammatory mode, which is fundamental for increased risk of cardiovascular problems, of cancer, endocrinological problems, and more. And finally, genetics. We all have the experience that not everybody gets sick and not everybody gets the serious disease. So early on, in our institution, Stefano Duga and Rosanna Celta did, I think, one of the first, possibly the first genetic effort to understand genetics and interaction with the virus. And let me say something. We always put our data as soon as there is a minimum of they are complete in open access. So we are not talking about phantom data, as we have heard a number of phantom data in the last few months. So that's, and then there was a large effort, and again, the international nature. And here I think it was San Gerardo, ourselves, Policlinico, and then Spain, and then Germany, Kiel, and then Norway. And this is the New England paper. And the message of the paper, this is a Manhattan plot. And the message of the paper is chromosome 3. There are genes in chromosome 3. Actually, this is a Neanderthal region. We got it from Neanderthal, crossbreeding with Neanderthal. And chromosome 3. And there are genes here which are dear to my heart because they are chemokine receptor genes. And we were involved in the discovery of chemokines. And then blood groups here. So does this hold to further testing? Well, this is rock solid. I happen to know the data in UK. 2,500 subjects, rock solid here. So inflammation, genetic connection to inflammation, and this is risk predisposition. The blood group that caught the attention of the media, so a dissociation between science and media, the blood group, the GRAP group, is not so solid. Was not confirmed in other case lists, so question mark. And again, the humility of science. Data are data. If your data are not reproduced, then you say they're not solid data. They're not, it's not so important. That's a fair way of summarizing the situation in terms of genetic predisposition. The virus, and I'm going back to genetic predisposition because there's been fantastic work done by Jean-Laurent Casanova and Gigino Tarangelo, with contribution, very important contribution by Andrea Biondi and University of Bicocca. So the virus interacts with the first line of resistance, innate immunity, the macrophages that I mentioned. And let me remind you that this first line of resistance takes care of problems most of the time. It is estimated that this first line of resistance that we call innate immunity takes care of our problem in over 90% of the bad encounters that we make every day. And here, when we drafted this slide with a minus on the interferon, I mean, there were no data actually. It was a postulate based on SARS. And I will get back to that. And then, of course, there is adaptive immunity, and Domenico already mentioned. Here are the directors of the immunological orchestra, the T cells. And I should mention that work done in particular at Karolinska by Hans Gustav Ljunggren has given a different perspective on T cell in terms of exposure to the virus. And here are the B cells. The B cells mean two things. First, diagnostics, serology, and then therapy. Let me just say a word about therapy, plasma therapy. It has been widely used, but unfortunately, the three large trials that have been conducted in China, in India, and in Europe have not shown a therapeutic benefit of plasma therapy. I have a strong prejudice that antibodies, so plasma therapy is antibodies, but not only antibodies. I have strong, as an immunologist, I have a vested interest, if you pass me the definition and the bias, that antibodies can help, but the jury is still out. And there may be good reason. I'll get back to the good reasons for the failure of plasma therapy. And then you have monoclonal antibodies, and Tony Fauci mentioned the emergency approval. Again, this was half a success, possibly a success, and half a failure, because it failed in the advanced disease patients, but some results with a reduced risk of hospitalization. And the paper is now out in New England Journal. A comment on T cells, the work done by Hans Gustav Ljunggren and NK expert as Domenico Maviglio, I should say, that is an outstanding NK cell expert. And Hans Gustav Ljunggren has shown that a number of subjects who are negative for antibodies are positive for T cell responses. So the antibodies are just the tip of the iceberg of a complex response, immune response, which includes first line, innate immunity, B cells, and the various specialties of the directors of the orchestra. So antibody means epidemiology, because it's easy to do epidemiology. I think that this was the first large study, 4,000 subjects. The study is led by Maria Rescigna, showing the different prevalence of antibodies in the Humanitas community in different areas, and here, of course, is the Bergamo region. And perhaps this is contributing to the lower incidence of disease that we experience in these days in this area, together with behavior, I think. So going downstream of the interaction, recognition, response, there is uncontrolled inflammation, defective or inappropriate T cell responses, late appearance of antibodies with mixed pictures, a cytokine release syndrome. It's not really a cytokine storm. It's not the usual sepsis, but the cytokine release syndrome, a macrophage activation signal, involvement of endothelial cells and coagulation, and downstream you have the pneumonitis with typical picture. Let me remind you that radiology is one of the pillars of diagnosis. A wise physician, a radiology TAC, and then the diagnostics, the usual RT-PCR are the pillars. MIS-C, a new disease, and Tony Fauci mentioned that, acute respiratory syndrome and multi-organ failure. And here are the two pillars of treatment, and that's heparin and glucocorticoids. Let me say a word about glucocorticoids. This was the large study published in The Lancet by Horby et al. I have a connection with the UK, and actually when this study was proposed, there was skepticism because it went against current wisdom. And this is the importance of the national health system as an extended laboratory in which you test in a rigorous way ideas and therapeutic possibility. And in this particular case, it was dexamethasone, which was mentioned. In general, it's a class activity of glucocorticoids, and they have reduced mortality. It's the only treatment that has been proven in large, controlled clinical trials, plural trials, to affect mortality. And then heparin is the other pillar, together with oxygen, of course. And these are the confirmatory trials for glucocorticoids, and Maurizio Cecconi in our institution was part of this WHO story. I would like to remind, since there are medical students and possibly physicians listening to me, that glucocorticoids are more than suppressors. They elicit induction of some of the brakes of inflammation and immunity, and it will be, I think, one of the challenges that we have is to try and see if we can understand who is responding to glucocorticoids, who is not having benefit of response to glucocorticoids. Let me go back to innate immunity and immunology, because I think we are experiencing a changing picture. And these are two studies which appeared in Science. Two studies. The main investigator is Jean-Laurent Casanova, and Gigi Notarangelo is part of. Unfortunately, Gigi is one of the most dramatic examples of brain loss from this country. He's now at NIH. And in these two studies, this is the first study shows it's not here, it's not genetic predisposition, chromosome 3, rock solid now. This is actual in what we call now inborn error. The IUIS, International Union of Immunological Society, has endorsed a new nomenclature of immunodeficiency. We call them inborn errors of immunity. And these are inborn errors that affect the interferon pathway, innate immunity pathway, leading to production of interferon, which is obviously is an antiviral molecule. And this is responsible for a few percentages of the patients who have life-threatening COVID-19. And I should mention that in these studies there has been an important contribution from this country, in particular Andrea, San Matteo, and other institutions. Andrea means San Gerardo, so Andrea Biondi. And then the other aspect, I think this is very, very important. In COVID-19, we have autoimmunity. We didn't know that. Again, a few percentages of the patients, there are autoantibodies that block the same pathway. But in addition, there are autoantibodies directed against, for instance, endothelial cells, and which affect hemostasis and thrombosis. There are antibodies that are reminiscent of the antiphospholipid syndrome, which I hope that the medical students and the physicians remember what it is. Antiphospholipid syndrome, and which are believed to be extremely important for the thrombotic complications. So the vascular involvement, the thrombotic complications, and autoantibodies are likely to play a role. So so this is a matter of reflection for the hyperimmune plasma therapy. Are we transferring autoantibody that triggers thrombosis? Is this why it didn't work in controlled trials? Question mark. And the general comment is that the general picture of the disease is changing. It looks now like a disease being at an interception, of course triggered by virus, this is obvious, at the interception of autoimmunity, immunodeficiency, and uncontrolled inflammation. So this general picture and the patients call for distinguishing different subsets of patients. And I think that we have a challenge of giving the right approach to the right patient. This is the general challenge. And with this, I want to share with you a piece of recent work that was done at Humanitas by the Humanitas COVID-19 Task Force and by Alessandro Rambaldi and Giovanni XXIII Hospital in Bergamo. And I showed you a picture in cancers and fundamental discovery. So many years ago, Martino Introna in my lab and Ferruccio Breviario in my lab, in the lab actually of Elisabetta Deiana, fundamental research, gene discovery. We discovered a molecule and then a family of molecules that we call long pentraxins, and this is pentraxin 3. We cloned the mouse, the human, DNA, cDNA, genomic, characterized the promoter, the structure, and more. And we are still working on this family of molecules with question marks, still big question marks. So what it is? And so this is the picture. This is when we have seen for the first time the actual molecule, cryo-EM. It's a functional ancestor of antibodies. So at the time, hundreds million of years ago, most life on Earth survives without adaptive immunity. And you have molecules like these long pentraxins in Limulus formiferus, who is a remnant, an evolutionary remnant. And what does it do? It has properties similar to antibodies. It binds microbes. It has opsonic activity. It regulates complement and regulates inflammation. It is essential, and we have learned it in patients. And there is genetic work with now thousands of patients showing that if you have the wrong gene, you are more susceptible to selected agents. Actually, we had evidence that it is important for a coronavirus before. So we looked, and this is work that was done by Enrico Brunetta, Marco Folci, Barbara Bottazzi, and others, again, in collaboration with Professor Rambaldi at Giovanni XXIII and the whole team at Giovanni XXIII. So we looked at, we have done RNA-seq. This is what you do these days in PBMC, and we found that one of the genes was PTX3, very high. These are our patients. And this is the fantastic world in which we live. I mean, then we examined the patients. We mined the data in patients in US, in Israel, and this is Sarah Mabelli, who did actually the bioinformatic engineer. And the gene is there. It is induced in infected cell lines. It is present in the peripheral blood. It is present in the lung, in myelomonocytic cells, so in macrophages. And this is autopsy samples in Bergamo. This is work done in Bergamo. It is expressed in many cells, in particular in vascular cells. For instance, here in vascular cells surrounding a thrombus. So this is, as Tony said, this is critical. So myelomonocytic cells, macrophages. So we have antibodies, we have an ELISA, our own ELISA, and this is the take-home message. You measure PTX3 at the beginning of the story, in the first days after hospitalization, and high PTX3 levels are associated with risk of death. And this is an independent biomarker. And this data, and this is independent, you have all the details here, and this is and those were 96 patients, Humanitas patients. These are 54 patients in Bergamo, and there is now an independent case list in Bari, 75 patients, same story. Strong, independent predictor of severity of disease and death. So we hope that this will help. We'll have to stratify, we'll have the physicians who are using the distant relative of this molecule. I forgot to mention that the distant relative of this molecule is C-reactive protein. So we hope that this will help physicians as an alert sign of severity of disease. We hope that this will help to stratify patients in clinical trials. And this is the take-home message, a gene that we cloned, fundamental research. We looked at it in cancer, mechanistic studies, genetic studies in cancer and in infectious diseases. It is induced by SARS CoV2, by inflammatory cytokines, in myelomonocytic cells and vascular cells, which are strategic for some of the manifestations of the disease, of severe disease, thrombosis, as emphasized by Tony. Downstream, this molecule is involved in recognition of microbial components. You may guess that we are working on it. It's involved in regulation of complement. We are working on it. It is a regulatory inflammation. We're working on it. And this has popped up as a potentially important biomarker of disease severity with strong independent prognostic significance. So again, the challenge, just to make this was hard data for the Virgilio students, and the general message is that one of the challenges we have is to dissect the diversity of COVID-19 and design approaches, including therapeutic approaches, designed to different subsets of patients with genetic predisposition, with autoimmunity, with different levels of inflammation using classic and new biomarkers, such as the one that I showed. By the way, that is a low-cost biomarker, low-cost, simple tech. Everything I would like to end my talk with a couple of comments on vaccines. Let me just say that there are over about 200 vaccine hypotheses in preclinical studies, more than 40 vaccines in clinical evaluation. Depending on how you you classify them, 6 at the late stage of clinical evaluation. And this has been pictured as a race. And in a way, it's a misrepresentation because it's a peculiar race, because it's not so important to get there first. It's important to get there with optimal safety and efficacy. And I want to remind everybody that A couple of months ago, WHO declared Africa free of wild-type polio. And we could have a world free of polio. And the world is free of polio not because of a vaccine, one vaccine, but the world is free of polio because of two vaccines, which have been used in a complementary way adapted to the setting. In addition, if you really want to have a world free of polio, we need a third vaccine, which is very hard to assess these days because there is no more polio, so not easy. But we need a third vaccine. So I hope that there will be more than one vaccine, because I don't think it's good to have a monopoly, because I think for the sake of subjects, for the sake of humanity, it's good to have more than one vaccine. I started off with innate immunity, and I would like to finish this talk going back to innate immunity. I mentioned the plasticity and diversity of macrophages. And there is, as I mentioned, there is a phenomenon that was originally described in insects and was revisited by Simon, by myself, and then Mihai is the one who actually did the mechanistic work and the translational work. There is a phenomenon that we now call trained immunity. And this has to do with the basal tone of innate resistance. If you pass me the word immunological, baseline immunological fitness. And there is evidence, preclinical evidence, and now very strong clinical evidence. There is a JCI, Journal of Clinical Investigation paper, just out on the same subject. There is evidence that you can increase the tone, fundamental immunological fitness. And we know that vaccine can mediate what has been called pathogen agnostic protection. The most dramatic example of that, I think, is measles. You vaccinate against measles and you protect against respiratory tract infections, which are unrelated to measles. The same is true for BCG, the old Mycobacterium tuberculosis vaccine, and this is mediated by myelomonocytic cells. Mechanistically, it depends on epigenetic remodeling, and in that's up with what has been called by Mihai and a strained innate immunity with increased microbial killing, cytokines, fluid phase pattern recognition molecules such as the anti-antibody I discussed, PTX3, and ultimately a better response in terms of adaptive immunity. And there are a number of trials now ongoing, at least 10 clinical trials, prospective clinical trials, which are aimed to assess whether we can actually make use of trained innate immunity to increase general immunological fitness to cope with COVID-19 pandemic. And there is a hidden question, and that is, do the current vaccines that are in phase 3, do they elicit trained innate immunity? Do they have this plus? And this is an open question. So I'd like to finish with a global view. Tony, again, and I want to mention that, of course, we are, and I am personally worried about global health in the context of COVID-19. And I've been part of a global health initiative called Gavi, Global Alliance for Vaccines and Immunization. And I served in the board of Gavi for 5 years, and now Angela Santoni, who is the president of the Italian Society of Immunology, called SIICA, Angela serves in the board. So Gavi is not only a good Italian wine, it is also a global health initiative that its objective was vaccines and vaccines for the poor. The 73 countries, the poorest country in the world, because at the beginning of the new millennium, 2.5 million children died because they didn't have access to the most elementary vaccine. Now the situation is still awful, but has improved. 1.5 million is the current estimate, or perhaps less. And this is in part thanks to this global health initiative. So Gavi and Seth Berkley, who is the CEO of Gavi now, has been the real driver for a global initiative to share the COVID-19 vaccine with the poorest country. I want to remind you that 1 kid out of 5, one Homo sapiens kid out of 5 who's born on the planet does not have access to the old vaccine repertoire, the simple vaccine repertoire. And before the COVID-19 pandemic, Angela Santoni, Rino Rapoli, and I had a paper in JXMed, and our statement was that, and I think that this sentence was borne out by the COVID-19 pandemic. So our statement is that vaccines are an achievement of civilization, represent a human right. Don't forget the 1 child out of 5 who does not have access not to the COVID-19 vaccine, but to the most elementary vaccines, to the whole spectrum of all most elementary vaccines. And it represents a safety belt or a health insurance for humanity. And this is based on fundamental research, as and immunology, as I tried to emphasize. And so again, our roots in Greek and Latin culture, Socrates, I know that I don't know, and still true that I don't know a lot about COVID-19. And the other message is that nature is fond of hiding herself. And again, we have seen that with COVID-19. And substitute nature with SARS CoV2, of course. And I think the challenge for you, the next generation, there is a program called Next Generation EU. I would say next generation scientist, next generation physician, next generation physician scientist. And this is this is a painting by Lucio Fontana. And I think that the challenge is to go beyond and understand and share. And I thank you for the privilege of being part of this conference. And of course, I'm open for questions.
Thank you, Professor Mantovani. We open the session for question and answers. Please select the option all panelists, and Professor Mantovani will directly look at the questions and answer. Thank you.
Shall I select the questions?
Yes, I would suggest you select the questions most relevant. We can consider 20-25 minutes for questions.
Okay. I guess we start with well, one question is, what pathway would you suggest to a young student in molecular biology who wants to investigate the secrets of the immune system? Well, go to a good lab. Go to a good lab in Italy if you are in Italy. Choose a good mentor, and then have some time abroad again in a good lab. And then follow your inspiration. I mean, take the challenge. That's my advice. But a good mentor, a good lab is key. So could PTX3, this is Nas Tusger, could PTX3 become not only a sign of severity of disease, but also a way to suspect COVID-19? Or is it specific like CRP, even if sensitive? It's not specific. There is nothing unique to COVID-19. Actually, previous study, one of the rationale for the studies was work that we did originally, and that has been repeated all over the world, on, for instance, sepsis. So in sepsis is very high, and there is a meta-analysis of all the trials that have been run showing that it is a strong independent predictor of disease severity in non-COVID-19 sepsis. So it's not specific. Let me just remind you that since C-reactive protein is mentioned, is that when you have you measure C-reactive protein, you measure a cascade which and IL-6 that induces C-reactive protein in the liver. Whereas this molecule is made by myelomonocytic cells and by endothelial cells, and it's made in the local tissues. So they may be, we think they are complementary. Scrolling down. Are people with autoimmune disease more at risk when they are infected? So, no, there is no evidence. I've had the privilege of interacting with Carlos Selmi, who is a rheumatologist, outstanding rheumatologist, with Antonio, who is a fantastic dermatologist, a physician scientist. No, there is no, to the best of my knowledge, no increased susceptibility to COVID-19 in autoimmune. Well, is the vaccine indicated for this kind of people? Well, of course, we have no data. So we have no data. We can speculate about that. But we will. There is no reason, in principle, why there should be a problem. And actually, I should say that, to be frank, I think that the type of communication made by the company without showing the actual data, I think it's irritual, and I'm ill at ease with that type of communication. Delta 13. Another question is related to HIV, because the president is CCR5 Delta 32, which protects against HIV. With such a mutation makes carriers highly resistant to HIV. Was something similar found for SARS CoV2? Nothing like that has emerged as of today. But don't forget, we are in less than a year, we have learned more in terms, for instance, of the diversity of the disease, of biomarkers. We have learned more than for HIV. I mean, for HIV to discover the Delta 32 mutation, it took, as far as I remember, about 20 years. Domenico may correct me. 15 years, as far as I remember. So, what sets the BCG vaccine apart? In that it may train the innate immune system? Well, we don't think that this is unique to BCG. BCG, because pathogen agnostic protection has been observed with a variety of vaccines. there were actually the very first observations were made in Russia with the polio vaccines. They observed that with the polio, with the Sabin vaccine, they had protection against infectious diseases. This was ages of 50 years ago, more than 50 years ago. So it may apply to many vaccines. So this is why I say vaccines represent good training for your immune system. And that is an additional reason why one takes vaccines. And there are people, including myself, but it's not just me, who feel that perhaps the resistance, the relative resistance of children to COVID-19 is related to the constant training that they get with the vaccine schedule. We have no proof of that, I should say, but that's a possibility. But BCG is the one for which we have more epidemiological evidence. Again, as I mentioned, just a recent paper in JCI, and the one that is amenable to a prospective trials. And there are about 10 trials in the pipeline. So I would like to ask whether there are some known immunological mechanisms that could explain why some patients worsen suddenly after days of clinical stability. Unfortunately, I have no answer. And again, I think that one of the challenges that we have is to dissect the diversity of the clinical course of patients and provide appropriate assistance and treatment to different sets of patients. It's a challenge. Good morning. Could you please speak about the advantage of mRNA vaccines, also in terms of clinical trial speed? Thank you. Yes, I think I can actually I think my time is over, correct?
Yes, but Professor Madhavani, we have time till 12:50 for the questions.
Until
12:50.
12:50. Okay, so we have plenty of time. Yes, just a second. Yes. The mRNA vaccines and the viral vector vaccines represent a shortcut. It's relatively easy to generate an mRNA vaccine, and this is at this stage the main advantage of mRNA vaccines. Again, let me emphasize again that this is the result of fundamental research and of cancer research. On the one hand, BioNTech is a biotech company that was funded by Christoph Huber, by Ugur Sahin, and their objective was cancer. And then they applied the technology. So it's a shortcut, and we should be aware of that. And let me emphasize also another aspect. Failures are important. Let me show the example of the vector vaccines. The Oxford group was fast in getting an adeno-based vaccine because they had the experience of generating a vaccine against SARS, and that is and that has provided the background to fast generating another vaccine. Mutations. I have problems with my. There's been a jump in the questions, but it's What about China? Is it propaganda? Well, I have strong ties with China, and I think that we have as an institution we have an agreement with a hospital in Wuhan. In March, early March, they were very useful. We trained people who went back to Wuhan. I cannot comment on data in China because I'm an immunologist. I'm not an epidemiologist or a public health, and I don't think that we are here to just a coffee conversation. So I will not comment about that. There is a question about the virus stability, and this is a major problem in that, and this is a communication problem. The virus is a RNA virus. HIV, as we heard from Tony and from Domenico, is very unstable. This virus is relatively stable. I'm not a virologist, but I have to follow. Of course, you have to know your enemy, and in addition, some of my molecules, the molecules discovered in my group, have been shown to be relevant to antiviral immunity and reported in Prime Journal, so I can speak. So there are only 3 reports on which we can make consideration, plus 1 from the Lombardy region. Early on, Fondazione Cariplo, which is supporting the Virgilio program, Fondazione Cariplo supported sequencing of the supported sequencing of the virus, and there were sequencing of 350 viral isolates in the Lombardy region. And now there are over 10,000 sequences. And what is the take-home message? Well, first of all, there is no genetic evidence that the virus has become less aggressive, that a viral, and this has been said in the media, unfortunately, it has contributed to irresponsible behavior, but this was a message without any data. There is a report, there is a mutation at amino acid 614, which possibly may have made the virus more aggressive, better, more infectious. In addition, in the Lancet, there was a report again of a loss of long reading frames of the virus, which occurred in China, then moved to Singapore. But in Singapore, it only affected a few, I think there were about 20 people. And then it was lost. No advantage for that variant, no positive selection for that variant. They really don't, or at least I don't understand the biological significance of that loss. And then another report in Cell, again reporting some mutations, but without a picture of. So the virus, some of us have been saying this since springtime, has not become more gentle. And there is a fundamental difference between the pathogen, namely the genetic constitution of the pathogen, and the disease. The disease is dictated by the weather, by summertime, by being fat, and so on. 2 different things. And we have learned this the hard way, I think. Is it relevant for vaccines? Well, for the time being, the major target, spike protein, is stable. So we have no reason to worry for the time being. But still, this is a very important question for the future, because it could well happen that in the future, a variant with a different spike protein emerges. So again, we have science is our safety net. And so we should monitor the virus, we should know if there are mutations, and act accordingly. Another question, the mink. Yes, there is a data on mink, but as far as I can see, the mink, there is no evidence that there has been a change in aggressiveness or mutation in spike in the virus that spread from man to mink and mink back to man. I don't think there are more questions. Yeah, I think Paola, unless any questions, I think it's over.
Thank you. Thank you, Professor Mantovani. Professor Biondi, could I request you to conclude the session in that case?
Okay. So thank you very much, Alberto. It was really a fantastic talk, and I was very impressed as well, even during the Professor Maviglio question and answer session, how all the students and participants actually were very active. I was very impressed by the quality of the question that in my opinion underline how it is very important to bring science and research in the context of the medical student training. So thank you very much indeed. I want to thank Professor Maviglio as well, and of course for the opportunity to provide to us the personal link in terms of history of Dr. Anthony Fauci, but as well to provide to us the opportunity to have him, although recorded, to provide to us a fantastic talk. As well, I would like to thank Dr. Paola Maria Di Palma for the very important IT support, and that basically provide with minor inconvenience, I would say, a very smooth running of this seminar. And as well, Dr. Rossella Guido for the communication support, as well for the communication with the offices of the University of Milano and Humanitas as well. So I think you have all provided to us a really fantastic morning, and I would like to conclude with a very simple, which is of course a recommendation to all the Virgilio students. Be proud of being Virgilio students, and please diffuse this experience to all our colleagues. Definitely our university will continue the program, and we hope as well that the Fondazione Cariplo, by touching with their hands on the deep and the quality of this program, will further support, because as Alberto said, it's absolutely mandatory to have medical students engaged into biomedical research since the beginning. And so with these words, I would like to thank all of you for this morning, and enjoy your day and your weekend. Thank you.
Thank you, everyone. Thank you, Professor Biondi.
Thank you. Ciao, Alberto.
Bye.
Chico.